Dear ladies and gentlemen, dear colleagues, welcome to this broadcast from the eCancer platform. And it is my great pleasure to introduce to you my fellow faculty members here, Professor Karim Fizazi from France and Professor Johan de Bono from the UK. My name is Laura Krabbe. I am from Germany, and let's dive into today's affairs. We are fortunate to have these two world-known experts here to talk about prostate cancer. And we will talk about lessons learned from the last decade, but also take a glimpse into the future. And because we have such ground to cover, I would directly dive in with the first question. Karim, maybe when we look into the last decade, what do you think about 10 years back when we were given oral drugs to treat our patients with mCRPC, about their impact and on patient care back in these days?
Right, thank you, Laura. So in summary, it's just been a fantastic decade. And I was not necessarily expecting so fantastic results in just 10 years, especially when I could leave the previous decade, the 2000s, where basically we're only able to show the benefit of docetaxel, which was a first. Before 2000 or 2004, there was nothing to propose with proven activity in men with mCRPC. Again, docetaxel was the first drug to show overall survival data, 2004. But seriously, between 2004 and 2010, we were, I guess, Johan and myself and others going to meetings and coming back home with negative data, especially typically trials testing docetaxel plus, a fantastic drug, which was not fantastic at the end of the day. So that was a bit depressing. But then starting in 2010 until now, I think every year, and I don't think there has been any exception, we had some new data, practice changing for the patients, mostly on grounds of overall survival improvements with quality of life going together. And that's been true with next generation hormonal agents. Obviously, Johan was really the first to take back the AR targeting in the game with abiraterone in the first phase 1 he conducted at the Marsden and then leading the first phase 3. But also some other drugs with new taxane, bone targeting agents with denosumab, with radium-223, PSMA targeting most recently, PARP inhibitors, and probably more is coming. So it's really been a fantastic decade. If I'm trying as a medical oncologist, trying to look a bit broader to other cancers, I'm not sure I can see any other cancers with so dramatic progresses, except maybe melanoma, because we were coming from so poor results in this disease. But otherwise, I think prostate has been the most lucky disease, if you will.
Yeah, thank you so much. I think with all the nodding going on, we feel very much the same. And maybe, Johan, you can comment a little bit on, the journey from these oral drugs, from the mCRPC post-docetaxel setting to the pre-docetaxel and mCRPC, but also then obviously to the earlier disease stages, MHSPC and NMCRPC, where we've seen such vast benefits with intensifying earlier, and maybe you can give us your thoughts and about this.
Thank you, and thank you, Laura and Karim. I think that for me, it is wonderful to see the the fruit of all the work we've all done, and I think in some ways it's also a bit surprising for me, although it should not have been surprising because the biology is there. But what's clear is that as we go earlier, we are, I think, getting a bit more benefit, maybe even a lot more benefit. And if you think about population statistics and how many cells you're trying to eradicate and the chances of getting resistance from tumor cells, it does make some sense using that population statistics model that if you treat earlier, you'll get more benefits. Although, to be honest, sometimes the hazard ratios are not that different in early stage versus late stage. And clearly, some of these trials haven't been designed to compare early versus late. Very few have. But I think overall, nonetheless, giving these drugs earlier is having major, survival benefits that are just wonderful to see, and we're serving our patients better with, I think, more active treatments. And I am really particularly excited about PEACE-1, which Karim has obviously led and presented at ESMO this year, because I do think combinations are going to be key to improving outcome. And obviously other diseases have learned that. I guess in neurology, the classic one is teratoma of the testes or seminoma. But as we combine drugs and maybe eradicate subclones that would cause resistance to endocrine agents, I think we're going to improve outcomes even more, although obviously at the cost of more, toxicity. But I think PEACE-1's data are, quite important for us and will, I think, have an impact on the standard of care.
Yes, definitely. And thank you for already, segueing wonderfully into the next topic. So we talked about the early intensification with quote unquote doublet therapy, but obviously the question arises, well, do we need to, or should we intensify even more? What about the triplet? And maybe Karim, you can introduce us a little bit more to PEACE-1, the results that you presented at ESMO, and maybe your thoughts on for whom the triplet is a good and correct choice after the data that you presented last weekend.
Sure, my pleasure to do so. So PEACE-1 is addressing two questions. One is the role of local radiation therapy in the context of intensified systemic treatments. And for this question, we don't have the answer. We need a longer follow-up because the analysis is event-driven. So we need to be patient. The second question is about the triplet systemic treatment. So in other words, should we use ADT, docetaxel, and abiraterone all together up front instead of just two of these systemic treatments? Before ESMO, we knew that from ASCO, we knew that doing so was associated with marked improvement in radiographic progression-free survival, with medians ranging from 2 years in the control arm versus 4.5 years in the experimental arm. So really big difference. But I know that many people were on the fence, hesitating to make this a standard of care for their patients with de novo metastatic disease. And overall survival data were obviously needed to convince at least those people. So this is what we reported at ESMO earlier this week. And indeed, overall survival is improved with the triplet treatment, with a 25% reduction in the risk of death in the overall population of patients receiving ADT plus docetaxel plus or minus abiraterone, including both high volume and low volume patients. When focusing on patients with high volume disease, data are clearer, and actually medians have been met. 3.5 years overall survival in the control arm and more than 5 years in the experimental arm. So more than 18 months, if you will, additional time of life for these patients, which is big, and that's a 28% reduction in the risk of death. And just to address Johan's comment, because I fully agree, some previous phase 3 trials were conducted in situations where not all patients progressing in the control arm had access to active agents. In PEACE-1, this is really what impressed me. More than 80% of progressors actually received at least one next-generation AR targeted agent, abiraterone or enzalutamide, and actually most patients received many different treatments, including taxanes and some others, which probably better reflects what we want to know. And I think this is probably one of the first clearer demonstration that earlier is indeed better than deferred with these agents, based on exactly what Johan explained. So, I mean, in my opinion, this is practice changing, at least for men with de novo disease, fit men, I totally understand and recognize that not all patients can receive chemotherapy or want to receive chemotherapy, of course. But otherwise, for these patients, when they have high volume, I think this is now practice changing. For patients with low volume, it's hard to say. The number of events is limited. Of course, death from prostate cancer is in competition with other deaths. So for overall survival, it's really too early to say. And we are actually planned to do a long-term analysis of PIS1 for this question. So we will need to be patient also to address this question. And for patients relapsing after local treatments, clearly PIS1 cannot address that because these patients were just not included. So don't ask me what to do. Of course, I don't know. But for patients with high volume de novo, I think, yes, for at least this is what I'm doing now. I'm proposing this triple therapy to these men.
Wonderful. Thank you so much. I would want to ask Johan if you think we can kind of extrapolate that to any new hormonal therapy that we could theoretically combine in this patient population. Can we just, assume that this will be the same for all the oral drugs, or is there a difference which we have to take into account?
Thank you, Laura. Well, we need more data for sure to become mature. And maybe I want to pick on, the point that has been raised already by Karim. What PIS1 is telling us, as are some of the other trials, including Stampede, is that earlier is better. Now, what that implies is that unless the biology of the lower volume disease is different, and I think that's unlikely, unless the lower volume disease has a different biology, with longer follow-up in PIS1, we will see survival benefit in those lower volume patients because the trial overall is telling us that earlier is better. So actually, if you take that message that earlier is better, well, lower volume is even more early. So it would make a lot of sense. And that, I think, has to be interpreted in the light of the population statistics, that earlier means less cells to eradicate, less cells to become resistant in that stochastic manner of resistance emergence. Regarding enzalutamide and darolutamide and apalutamide, obviously the combinations with docetaxel aren't really at this point in time able to advise us. We haven't got enough data to really go with. The Enzamed data so far have proved really inconclusive. And I think we need longer follow-up for those patients. But one of the concerns I have is that enzalutamide is a potent inducer of CYP3A4, and CYP3A4 actually impacts docetaxel metabolism. So we have to be a little bit careful that Enza and Abi can be quite different. Now, there are some limited PK data that actually indicate that Enza and Dosi had limited PK interaction, but I don't think those data, in my mind, were comprehensive enough. So no, we cannot assume that Enza is going to be the same as Abi. In fact, I would strongly advise that until we have data, we don't assume that, although it would not surprise us to see Enza getting the same results as Abi and Daro too. Although, we have to be sure and get data because that PK interaction risk certainly worries me, although it doesn't worry everybody.
Yeah, and you mentioned darolutamide, and we're all obviously keenly awaiting the readout of the ARASENS trial, where we will have another large phase 3 trial looking at the triplet combination question. And so I think that will hopefully reassure us that the changes we're making after PIS1 will last through. And I mean, as robust as PIS1 is, I would say it's very likely that we will have more data to really set the foundation for an even or not even earlier treatment intensification, but an early, more intensified intensification, if we will call the triplet that. Perfect. And maybe if we stick with Abi a little bit longer, because honestly, at ESMO, Abi didn't do it just once; it did it again twice when we think about the STAMPEDE data that came out in the M0 population. And Gerard Attard presented that data from the M0 STAMPEDE population, looking at, to be honest, a little bit of a mixed bag situation, with some patients relapsing after local therapy and some patients presenting with high-risk features of locally advanced disease initially. But maybe, Johan, you can take us a little bit more through what your thoughts on the data are, and what we should or could maybe change from now on.
Thank you, Laura. Well, I think the first thing to say from this trial is that, Gerhard Attard, who trained with me, hypothesized that abiraterone plus enzalutamide would be better than abiraterone. And I think it's important to note that actually that was not the case, because actually not all combinations are going to be better. And in fact, the Enza-Abi arm was no different to the Abi alone arm. So I think that's an important statement, which does not support giving abiraterone and enzalutamide with ADT. STAMPEDE, has the advantage of being a fairly broad recruiting trial with broad eligibility criteria. And that is an advantage because you recruit very quickly. It's also a disadvantage, and that when trying to really figure out the detail of benefits, one could criticize that, and I'm sure some will. But I think, as we've said earlier, we have a lot of evidence mounting from many trials now that earlier is better. So I don't think we should be surprised that for M0 high risk, abiraterone improves survival. And in fact, this is in keeping with all the other studies we've seen, including what we've just discussed, PEACE-1. So, I would argue that these data that Gert Attard presented support changing the standard of care for the M0 high risk CSPC or HSPC patients. And certainly, if that was me, I would be keen on getting abiraterone. But you are, I think you have the right to argue that this is a slightly broad population eligibility criteria of M0 disease, node positive, higher PSAs, faster doubling times, and that may, be needing further, consideration, further studies. But certainly I do think these data, in my mind, should impact clinical practice for high risk, locally advanced M0 HSPC, and that this is in keeping with the overall direction of travel, that earlier is better. Now, I say this with some caveats. Prostate cancer is not one disease, it's many different molecular subtypes. And it is likely that, earlier abiraterone is not going to be better for all, bad prostate cancers. And I'm sure that a lot more work needs to be done to, interrogate this further. But I don't think it's unreasonable to be thinking about giving these men, abiraterone and prednisone.
Yeah, the data are definitely showing a strong benefit. And I think the pendulum towards where intensification is maybe not beneficial anymore doesn't stop at high-risk M0 disease. However, maybe many colleagues might be faced with problems with approval status of the tested drug. Karim, maybe you can comment a little bit on if we can expect, or maybe how even societies should think about approval of drugs in a data space that is so strong for so many situations.
Right, I agree. This is truly a big issue, potentially, especially when a drug becomes off patent and when it shows massive improvements. I think this is where guidelines are also important to support us with use and with discussion with other societies or insurances, depending on which health system we are dealing with. I actually fully agree with what Johan said. I've already started proposing abiraterone in selected patients with high-risk localized disease, although it's not fully approved and reimbursed. But I think when we, as doctors, when we see data so strong, based on thousands of men randomized, with so big differences, not only in terms of time to relapse, but most importantly, overall survival, with a hazard ratio of 0.60. I think simply as doctor, we should make sure the patients can benefit. So this is the kind of thing we would typically hear validate in the multidisciplinary meetings, so that we all write down on a piece of paper that we agree that this is the way the patient should be treated. And if at the end of the day, the society comes back to us and say, why the hell did you decide to use this drug? I think we have strong data, to provide. And also the fact that we agree as doctors is also important. And again, when it's supported by guidelines, it's also very important. But this is a good point. And if I take the Taxol in the M1 castration-sensitive disease back 5 years ago, we actually started using it off-label, and finally Sanofi decided to go for an approval, although the drug was generic, which I think was a good thing from a company, not necessarily their financial advantage, but just to make sure they were doing things the right way. So I think that I hope that Janssen will do the same for abiraterone in the setting. That would be just good for humans, for patients.
Yeah, I fully agree, and thank you for making this strong statement towards this situation. And Johan previously already said that prostate cancer is not one disease. You talked about the differences in molecular subtypes, for example. And obviously, since the beginning of this year in Europe, we have the possibility of using the first molecularly driven, or at least test-based driven therapy with PARP inhibition. Maybe you can comment a little bit on the PARP situation, when you would ideally use it for our patients, and what you see forthcoming with other molecularly driven therapies.
Thank you, Laura. PARP inhibition is approved in Europe for BRCA alteration prostate cancers, advanced CRPC. In the US, it's got a broader label, including multiple other DNA repair defects, where we know PARP can sensitize, including ATM, FANK, PALB2, I mentioned some, and those all sensitize to PARP. So we now have a stratified subset of prostate cancer that we can treat with PARP inhibition. I am fairly confident that will expand in Europe, and that actually PARP inhibition will also have utility, not only early, but later, because I think what we're seeing is prostate cancer evolving to develop alterations that are emerging with endocrine resistance that will sensitize to PARP inhibition. So there will be a need for these drugs, both in the early and later stage space, I think. And importantly, I think as the combination trials, come towards fruition, it's going to be interesting to see whether endocrine therapy with PARP inhibition is going to be impactful by preventing the development of those clones. Obviously, we have AKT blockade emerging as well for PTEN loss prostate cancers. We have immunotherapy for the mismatch repair prostate cancers and maybe others. So I think, there's a lot of hope that we're going to get more molecular stratification, which could change patient care even further in the near future.
Yeah, thank you. And obviously, this will make it a little bit more complicated for us to select patients for the correct treatment, sequence them accordingly, and also make sure that logistically the patients can get to the experts that can treat them with the respective drugs. And maybe coming to an overlap with a different specialty, because this has been a wonderful year for prostate cancer. At ASCO this year, we saw the VISION study looking at PSMA lutetium ligand therapy, and that obviously will be a big interactive effort to make sure that our patients can transition from being in the expert care for the oral or IV drugs, going to a nuclear medicine specialist. Maybe Karim, you can briefly comment on what you think the scope of vision opens for our patients, and also maybe where we can expect it to land in the sequence.
Right. So regarding the treatment, PSMA lutein, well, first, it's great to finally see that there is overall survival benefit on top of quality of life benefit and progression-free survival benefit with this treatment, which was suspected for basically a decade or so, based first on individual data from your country, Laura, because this was invented in your country, and then some phase 2 trials from Australia, which is really the first phase 3 demonstration, Solival 1. So that's great. Now, as a broader thing, it means also that PSMA is an important target. So we might be also able to invent new ways to target this target, not only with radioisotopes, but potentially with BiTEs, maybe ADCs, et cetera, et cetera. So this is also something we should watch. And at the end of the day, try to better understand the biology, how cancer cells can resist to this treatment. Can we target PSMA several times? Yes or no? And as we already discussed it, should we use PSMA targeting earlier in the course of a disease when the expression of a protein is already there? So those are open questions, obviously. But you're very right. There are also very pragmatic and practical consequences to that. For example, in the trial and in many previous experiences, selection was based on PET PSMA, which is not available everywhere. It might sound crazy for you, Laura, I guess, because in Germany, I guess it's quite easy to get, but just cross the border and you'll see that here, and Johan may comment from the UK, it's not that easy. And what I'm telling you, it also reflects, many parts of the world. So those are important and practical questions. If truly, say, the EMA decides to approve the PSMA lutein in patients with demonstrated PSMA avidity on a PET PSMA, it means that we will have to do a PET PSMA. And then many countries in Europe will be in trouble just today or tomorrow. So those are things we need to learn. And actually, this is also true. You were mentioning, or Johan, I can't remember both, the need for sequencing cancer cells or cancer tissue or ctDNA to better understand what's ongoing before making a decision, which obviously is the way forward. But this is also something that's not necessarily covered by all the systems in Europe. And I know that in the US system, it would be very different because this would be a discussion, individual discussion with the insurance, or the patients would pay out of pocket. But in Europe, we have a different system. So we have to discuss probably individually with all our own countries to make sure that patients who need tissue sequencing can actually access to that. And that's not a given. All the lung cancer colleagues have been quite successful, at least in my country, doing this with obvious good reason to do it and important clinical consequences to the patient. For prostate cancer, this is something we should now do based on the demonstration that PARP inhibition works, and hopefully soon some other drugs.
Yes, I think that's one of the great challenges that we will face in the future. I mean, obviously, how to combine, how to sequence, but also how to get people access to what we know is working. And so maybe that's also a good segue to maybe my final question to each one of you. With everything that we've heard from the last decade that was great with regards to the new developments for our prostate cancer patients and all the visions for the future that we have painted a little bit. Is prostate cancer a chronic disease yet? And what do we have to do to make it even more so? And maybe Johan, you start tackling that question.
I think for some patients, there definitely is already a chronic disease, but sadly, men are still dying, of advanced prostate cancer. So I think there's still, a lot of work to do, although obviously our job is to try and, finish our work and cure this disease. Now, we have emerging work, for example, that microbiota are making androgens and fueling tumor growth, which I think is going to be another really key area to drive forward the field and actually change outcomes. And I am very confident that actually there are many other new treatments that are emerging that will make a difference. But as we understand carcinogenesis, the next question is going to be, can we prevent this disease emerging, particularly in the higher risk patients like the germline BRCA patients, for example? And I really believe we can. And that is perhaps the biggest challenge for us all.
Wow, that's already a great challenge that you've lined out for us here. Karim, maybe some additional thoughts to the chronicity of advanced prostate cancer and what the future holds for us.
Sure. Well, basically, once more, I guess I fully agree with what Johan said. Regarding the chronicity, men with biochemical failures from prostate cancers after radiation / surgery. Of course, some of them are curable, but some of them are not curable, but still they will live very long. So this is already a chronic disease. And we deal with these patients for decades. So it's important to maintain their quality of life and try to avoid problems from their disease and from all the treatments. So this is the well balance to find. And actually, I would say the same probably for men with oligometastatic disease now. Men with multiple metastases, still have a hard time with several years of survival, even if we were able to show improvement in the last years. But oligometastatic disease really is, I think, is chronic disease. Now, regarding the new victories, I fully share what Johan said. Obviously, one thing which is striking to me remains that men dying from their prostate cancer mostly have their androgen receptor engine working. For most of them, of course, and I put aside the neuroendocrine differentiation, some very specific subsets. But in general, patients die with an active AR, which means that the story is not over. We still need to invent better ways to target the AR machinery. And I think we may just be about to start a new wave of a third generation of AR targeting after castration, which was the first abiraterone, enzalutamide, apalutamide, and darolutamide, which is the second generation. We need drugs that work when these agents have failed. And I think we're just about to see this happening. Johan presented some data at ASCO. We saw some others a year before with the Arvinas drug, and probably more is coming. So I think this will be super exciting and very important for the patients.
Yeah, thank you both for these great insights. And we already saw how time flies by when you talk about something so actively and, with all your heart. And so I think we have wonderfully recapped what we already reached within those last 10 years, but still where we also have some ways to go, but we're already on the way. And I think with this, I would like to thank you both for obviously your time and insight today, but also for your wonderful dedicated work that you provide to this patient group and all the help you've given us other treating physicians in caring for our patients better. Thank you so much.